Okay, everyone. Good evening. It's 9:01 on August 30th. Thank you for being with us again. And I'm putting slides in at the very last minute, um, fresh off the presses. But thanks for always joining and supporting. This would not be possible without the support from Terry Iman and the Georgia chapter of the Lupus Foundation of America. Thank you for all that you all do each and every day before, during, and well after the pandemic. Also, thanks to Representative Kim Schofield and Chris Reed and the others on the Georgia Council for Lupus Education and Awareness, one of the very few state-sponsored efforts to improve the lives of those in the state with lupus. I don't know if you knew that or not. And the Emory School of Medicine, where I'm faculty and I spend most of my time at Grady. And one of our big research projects is GOAL, Georgians Organized Against Lupus. And many of you have been very kind to support us through your efforts there. Okay. And this is just to remind you of the disclaimer that's on the website that none of this should be used to direct personalized treatment. So, what can we say? We're still marching. The US crossed the 6 million case mark. Worldwide, we're well over 24 million and 835,000 deaths. And along with the 6 million cases in the US, we have over 184,000 deaths. Brazil and India remain number 2 and 3. And still, the top 3 countries there comprise more than half of the number of cases globally. The hotspots throughout the world really haven't changed much from the last week that I reported compared to this past week. It continues to be well throughout the US as well as a big part of South America. And Spain has become a big hotspot too, and France. And just always reminds you that these things will keep coming back unless we continue to be vigilant. And so it feels good when numbers start coming down, but again, they could easily go back up. The US, it can be numb kind of looking at these maps week after week, but it just is so striking to me how certain parts of the country continue to be so blazingly hot. And we sort of glance over it, but when we talk about the US representing such a huge number and proportion of cases throughout the world, we're talking 6 million out of the 24, and then 184,000 deaths out of the 835. A huge chunk of the US, a huge chunk of the world's burden of COVID complications and infections are right here in the US. And within the US, you're talking about certain parts of the country. We're talking the Midwest and just a dramatic impact in the Southeast. There is a signal there of why. And we can continue to keep dancing around it in public conversations, especially the political issues have been trying to distract us from the main reasons why. But we have to keep our eye on the ball. We are driving, we here in Atlanta and throughout the Southeast are driving much of this, and we have to continue to remember that. Nationally, though, you can see from the week before that the cases continue to go down, and generally the cases are going down, primarily because of restrictions that are in place in most of the areas throughout the country, and no help to the certain areas that continue to fight back against imposing any sort of restrictions at all. The deaths are starting to slowly edge down, but you can see here that the cases are still much higher than the original spike, and the deaths, even though much less from the original spike there, is still quite high. And these are daily counts. 3 states continue to have a huge burden of the cases. California, Texas, and Florida have over 600,000. Georgia is number 5 in the number of cases with 260,000. And if you put it in terms of rates, meaning how many cases of COVID per 1 million in the population, Georgia is ranked number 1. So when you compare apples to apples in terms of cases per 1 million, we have the highest rate of new cases in the country. The Republican National Convention painted President Trump as a leader who has taken decisive action to save lives. The FDA gives the emergency use authorization for convalescent plasma. And we talked briefly about this last week because it was just literally a few hours before we spoke last week. Although, there's the FDA walked back an initial claim that convalescent plasma reduced mortality by 35%. They really overshot the claim. And again, a lot had to do with political pressure, frankly. And the CDC updated COVID-19 testing guidelines that suggest people without symptoms do not necessarily need a test. And we'll circle back to that in a second. The first clear case of reinfection was reported. Initially, it was thought that there was a lot of reinfection because the PCR test, the nasal swab, remained positive or would come back and become positive later on. But it turns out that the PCR test, that nasal swab, is so sensitive that it picks up little parts of the virus particle, even though the virus is not active or alive, if you will, and reproducing. So it just picks up little bits of it. Not necessarily infectious, but clearly someone has been reinfected. And there have been more than one case, and I believe the first one in the US was just recently as well. And that is not surprising. You're talking, millions of people becoming infected, and then most of them thankfully recovering. And there's going to be a high variability in terms of people's immune system recovery and susceptibility to getting infected again. And given the variations, it's not surprising that someone might get reinfected. The good news really is that we're not talking about thousands or hundreds of thousands of people getting reinfected at this point, and we're talking 6+ months into the pandemic. So clearly, this is an issue. It's going to happen. It was expected, but certainly it's not happening to the point where we have to be terribly worried about it. It does give you an idea of the high variability that we have as humans and the complexity and the beauty of the immune system. And for those of us that live with lupus and treat lupus, we're well aware of this, right? We have such complexity of lupus. Everybody's different, and people go up and down for a variety of reasons, for different reasons. So we know very well the complexity and the individuality of the immune system. And here, COVID is no exception to that. Going back to that map of the U.S. and how it affects certain parts of the country, and I've mentioned this before, what continues to be such a travesty really is kind of how the disparities of coronavirus and the impact on certain racial and ethnic groups is just glossed over. And the fact that so many people and venues and politicians talk about how many cases there are of the coronavirus, but yet don't talk about how there's such a greater burden on certain groups. It really speaks volumes as to the conversations that are being had or not had along these lines. And further to this point, we've heard about the racial disparities, especially in Black Americans, but also Native Americans, Indigenous Americans, Pacific Islanders and Latino Americans. And you can see here that the rates are so much higher than what's being felt in white America. And here, if these racial groups had died of COVID-19 at the same actual rate as white Americans, about 19,500 Black, 8,400 Latino, 600 Indigenous, and 70 Pacific Islander fellow Americans would still be alive today. So, and I'm still trying to put my thoughts together about this, but it's along the lines of what I've really felt strongly about in lupus. And frankly, what we try to do in our research group at Emory and through the GOAL project is that, given some of the national conversations that we've had, we've talked for so many years about how people of color with lupus do so poorly compared to white Americans, white individuals, even in Europe with lupus. And, I think every poor outcome is a travesty. But when we're talking about such disproportionate burden in certain groups and not coming to a specific answer and not being able to support it by saying it's purely biologic, the color of one's skin and the label of any of these racial groups, it doesn't tell you how different the immune system is. There may be some subtle differences, and I'm not saying it's not important. There may be some genetic influences, but what it's a bigger marker of are the social factors around that individual and living in this country or anywhere in part of the world with that color of the skin and what it represents with regards to the neighborhood and ability to access care. So, as you may be hearing about this conversation with COVID, I think is just directly relevant to what we deal with lupus every day in our communities, our fellow brothers and sisters. We just need to really keep this conversation alive and understand its relevance and what we're doing also in lupus. I think I have some slides a little bit out of order, but just bear with me. So this past week nationally, some news to bring up. This is thought to be potentially a game changer down the road, hopefully sooner rather than later. There's a new test that's out. And really that's one of the pillars of what's really going to bring us into normalcy, if you will, after this pandemic. One is the vaccine. The other is going to be treatments for those who get infected and have really severe complications from COVID. But the third is testing to know actually who has it and to be able to know it quickly and cheaply and accurately, and to be able to then say, okay, you should not go to school, you shouldn't work, you should take a few days off, you should get treated, you should get vaccinated. And we're totally in the blind here. We're just masking everybody up and wondering if it's in the air around us. Now here, Abbott Laboratories got the FDA to grant them an emergency use authorization for a test priced at $5 per test. And it just takes a nasal swab that's not as invasive as what you hear or might have gotten from these PCR tests that are out right now. You put it on a small card. It's much like a pregnancy test, if you will. You add some reagents or drops on it. It goes and it's covered with antibodies to COVID. And basically, if you have COVID, it sticks to the antibodies and then it causes a color change. So it can be performed in the home, outside of the lab. Abbott says there's a 97% accuracy rate in people with symptoms in the past 7 days. And they will hope to produce about 50 million of these tests by the end of October. It's not really clear whether those who are asymptomatic or who have symptoms after 7 days, whether the accuracy will remain 97%, but the fact that these technologies are starting to come out and being able to mass produce, not be subject to shortages of supplies and can be done at home or certain places very quickly and relatively cheaply is going to make a huge difference. This is a neat kind of dashboard, if you will, for those who have an interest or have children in places of higher education and the universities. So New York Times has this dashboard of the different colleges that are having numbers of outbreaks. And as of a day or two ago, University of Alabama, Birmingham was the top in the country, and UNC, followed by University of Central Florida. And you can see here that UGA was in the top 10. Georgia colleges and state universities. Georgia College and State University in Milledgeville is also sort of in the top. So Georgia, you can see that it's still very red and orangey, although it's kind of moved outside of the metro area, if you will. It's really continuing to ravage rural parts of the state, as you see. Then you can see the counties that continue to have a really high impact in terms of cases per 100,000. This is in Georgia, that you see the number of cases peaked in April, and then it just really started going up again in July. And you can see recently, compared to last week, that it indeed, I mean, we had a sense last week that cases were starting to come down, and it's starting to come down, but still very high compared to the early part of the pandemic. I mean, these are extremely high numbers, and that's, I mean, you may kind of look at me and say that I keep screaming the sky is falling, but and I want to preach good news, and it's good that we're going down in the direction. But what's so concerning is how quickly people fall and become complacent. And so, you know, again, this is good news, but it's no reason to be complacent at all. And if you look at the deaths in Georgia, it's still at a very high rate. And what looked as though was a period of going down, there's a very recent spike up. So we can't relax in terms of the poor outcomes as well. And just to continue to get a gestalt of the major parameters that we look at, you know, overall, Georgia continues to be at the higher end. It's not at the outbreak red marker, but it's right at the phase below, which means that it's at a high risk of an outbreak. We continue to have a high number of daily cases. The number of infection rate is still spreading, but slowly, which is good. The positive test rate has gone down to the 5 to 10% rate, which means that the testing has been good. And, you know, thankfully, the ICUs have not hit the limit and continues to be down in terms of the percentage of ICU beds that are being utilized. And the statewide and regional hospitalizations you see here, you know, statewide, we continue to slowly come down. We're down to, as of Thursday, 2,131 statewide hospitalizations with positive COVID patients. But again, compared to the lowest number, we were at 748 back in June. And we're not that far from the high on July 30th. And we continue to be around the 80s in terms of capacity with inpatient beds and ICU utilization. So a couple of questions. It's been recommended that basically someone's undergoing a surgery and they're wondering about whether it's safe, and especially in the context of maybe a possible second wave, and whether there are any other recommendations trying to get ahead with earlier appointments and getting extended supply of medications. Now remember that initial wave, which by the way, I keep reminding everyone, you know, this initial wave in the country, I guess if you can say this is really going down, it's not really going down, but maybe you can say this is wave one and we're kind of going down from wave two. You know, most people argue that it was just still the same wave, that we're just going even higher. But nonetheless, I mean, very early in the pandemic, we remember having businesses shut down, um, having hospitals overwhelmed. And that's because, especially early on nationwide, we're talking, even though the number of cases were not as high as they are now, the makeup of the individuals that were being infected were extremely high risk. I mean, we were just getting to know that people who were elderly, that had certain comorbidities like hypertension and heart disease and diabetes were at risk. Remember, it was spreading through the nursing homes, and we were just starting to catch up with that. So we're past that, thankfully, in terms of understanding most of those issues, being more careful in those high risk individuals. And so therefore, now, even though we have these high number of cases, we're not getting as many deaths because it's really the younger people that are driving it, although it's not purely younger, obviously. And it's not ravaging the elderly in terms of some of the places that they're at, the facilities that they live in. So when we talk about things basically are not going to shut down probably unless it's extreme. Thankfully, we were scared that it might even get to that point recently because the numbers were going so high, and we didn't know when exactly that was going to trend downward. There was no will in certain political levels to change anything. So, thankfully, we as individuals in the areas that are mandating masking and social distancing and closing of certain high risk areas, all that's making a difference, and things are coming down. And we're not, we have not overrun the hospitals. So as such, the healthcare systems, for the most part, are going to continue to remain open. They've learned to adapt to these things. They put into place procedures, some surgical procedures, and I'm not sure if this one in particular or what facility. I mean, there's some certain procedures where they'll mandate that you get a COVID test before doing it. And then certainly going in, there's a lot of testing done and safeguarding. So I think really the environment now is much different. But if we ever get to the point where we were just a few weeks ago when the numbers were extremely high, it would not have taken much, especially if we didn't, as a public, take on the masking and the social distancing and the care that we did. If a large percentage of the population didn't take that seriously, went along with what a lot of the politicians said, we would have easily been tipped over into the point where it would have been pandemonium again. Facilities would be closed, the government would mandate a lockdown, people would be forced to stay home, businesses would be forced to close, hospitals to a certain extent would be so overrun that they would stop doing these elective surgeries and shift everything in terms of resources to trying to manage the sick that would come in. So again, these are nightmare scenarios that we just keep flirting with, and hopefully we'll continue to do the right thing moving forward. So that's why these dashboards that we talk about and the numbers and the trends are important. And I think if we do start seeing these things going more and more to red across the board, that may be a time for us to really start thinking ahead of time as those who have lupus or care for lupus, whether we do need to take some preemptive measures, especially in terms of trying to get medication supplies. It's always a good time, I think, to start catching up with medical appointments, elective procedures, now that people know how to handle it better and things are not overrun. Some other regional news, the latest report from the president's Corona Task Force shows that Georgia had the second highest rate of new coronavirus infections in the nation over this past week, and it continues to urge state leaders to impose a mask mandate and other restrictions to stem the spread of COVID-19. The report notes that Georgia has made modest gains containing the number of new cases and the number of infections linked with nursing homes, though it again warns that those improvements are fragile without more aggressive actions. So, this incremental improvement from a week ago is encouraging, but these comments and these reports continue to show us that we need to be extra vigilant, and we need to continue to mask regardless of what the government says. And this just, stories like this continue to remind us that in some ways we are at the epicenter here in Georgia with regards to COVID issues. So it gets so boring to hear about this over and over again, but please continue to spread the word to your friends and neighbors that even though the numbers are going down, we still have a long ways to go. This is a research out of one of our major journals, Annals for Rheumatic Disease. And these researchers look to see the risk of hospital-diagnosed COVID-19 patients, and especially those with immune issues and autoimmune issues. And so these, again, hospitalized and becoming or being diagnosed with COVID in the hospitalization. And when you look at chronic inflammatory diseases overall, they had a higher risk of being diagnosed with COVID in the hospital compared to those who do not have a chronic inflammatory disease, about a 1.32-fold higher prevalence, if you will. And there are some differences, though, within some conditions, it seems. People with certain systemic autoimmune diseases like Sjogren's, scleroderma, or vasculitis had a 2 to 3-fold increase compared to the general population for 2 to 3-fold higher risk for being COVID positive in the hospital. Meanwhile, people with inflammatory arthritis and systemic lupus demonstrated no increased risk compared to the general population. Doesn't mean you're not at risk, but you're just at the general population risk. And again, there's certain caveats still. In addition, patients with inflammatory arthritis who are treated with targeted synthetic or biologic medications. I mean, these are some of the newer medicines, the ones that either you get through infusions or subcutaneous injections, or one of these newer pills that target a very specific part of the immune system. Those, as opposed to the more traditional pill medications like azathioprine and methotrexate, these conventional synthetic disease-modifying agents, these targeted synthetic or biologic drugs had a higher risk of being COVID positive in the hospital compared to similar aged patients from the general population that were in the hospital. Now, in a way, it's sort of good news. I think it doesn't point to lupus being a really, really high risk group. Again, there's still some caveats, and not everybody in this study was lupus. So their ability to have the power, the statistical power, in other words, the conclusions to be extremely strong as it relates to lupus specifically, was not as great as we want it to be, but at least it's another signal, along with other studies, which continue to kind of bring out the same theme that yes, people with autoimmune issues are at higher risk. There are a lot of caveats. There may be certain medications that put the risk a little higher than others. We are going to learn of certain conditions more than others that may be at higher risk. But generally, everybody with autoimmune disease is at higher risk. The good news is that lupus doesn't seem to be something that has a tremendously higher risk compared to others. But again, a lot of individualization here. There are a lot of really sick people with lupus on a lot of medications with heart disease, hypertension, diabetes as a result of the complications from lupus and the medicines. And that is certainly a recipe for an extremely high-risk individual for COVID, no matter what this particular study says. This is a study out of China where they look to see if people with autoimmune rheumatologic conditions may be more susceptible to COVID in the general compared to the general population outside of the hospital. And they compared people from families with COVID positivity and these conditions compared to families with COVID positivity in certain members without rheumatologic conditions. And again, we can't parse out specifically lupus data. These were individuals that had a lot of other types of rheumatologic conditions. Most of them had rheumatoid arthritis, about 2,700 individuals. The next highest number was in lupus, about 1,900 individuals. Sjogren's had 650, and then the rest were lower. But the researchers found that the risk of contracting COVID-19 was higher with more advanced age and the presence of a rheumatologic condition. The odds ratio is about 1.04. So it's not extremely high, but it was statistically significant. Sex was not a factor. They did find that people with rheumatologic conditions who were taking hydroxychloroquine were found to have a lower risk of COVID-19 infection than those with a rheumatologic condition not taking hydroxychloroquine. But I want you to know that it's not because of hydroxychloroquine having a magic effect in fighting. It's probably because those with hydroxychloroquine tend to be those with milder conditions. So I think the take home here is, again, this is more proof that people with autoimmune disease, rheumatologic conditions, including lupus, are at higher risk than the general population. But it's not like a 3-fold increased risk, 10-fold increased risk. People are dying 10 times more. I mean, it's an increased risk, and we need to be very careful. What do I make of the new CDC recommendations for testing and quarantine guidelines? And the press that came out was basically how the CDC at one point was saying that even if you don't have symptoms, but you clearly were exposed to someone who tested positive for COVID, you should get tested. And that makes sense because we know that many people can be asymptomatic and be infected and infectious with COVID. But again, due to political meddling and pressures, the CDC changed that to basically saying that you don't need to be tested if you were exposed to somebody who has COVID, but you don't have symptoms. And anybody that knows about this virus knows that that doesn't make sense at all. You should get tested even if you're asymptomatic, if you're at high risk, including being exposed to someone. And so here, they backtracked a little bit. They didn't specifically backtrack all the way. Again, it's just a lot of political pressures. And I think the take-home message is don't let this confuse you. If you're exposed and you're asymptomatic, you still may be infectious and you should try to get tested. Pretty simple as that. Just to underscore that hydroxychloroquine is not in the picture again as a treatment or a protective agent against COVID. This is basically a study that combined the results of 29 other studies that looked at hydroxychloroquine called a meta-analysis. And it's a group out of France's research institute. And it's the same conclusions that I've been talking about before, that there may be an increased risk when combined with azithromycin, that is, another antibiotic. And in certain people with other issues, it actually can make things worse in terms of their COVID. And it's not been shown to be protective at all against COVID. This is a study which has really made an impact in terms of some of the guidelines in the CDC and workplaces and healthcare industry. Let me just kind of walk you through this. Um, this is a timeline basically going from left to right. And let's say you get exposed around um, day -3, and then 3 days later, you start having symptoms. That's going to be the peak at which the virus is in your body and at which you're going to be infectious to other people. The majority of uh, people who then get infected from that individual happen within 5 days after the symptom onset. So the majority of secondary infections occur before 5 days. And really, it doesn't happen much after 10 days. So you may start seeing like places in the healthcare industry and certain occupations and companies and things like that modify their rules so that once after you have symptoms or test positive of COVID, 10 days is pretty much the standard for isolation now. You may remember kind of 14 days in the past and so forth, but highly unlikely after day 10. And even when you talk about the sick of the sick, the really severely critically ill people in the ICU, less than 5% probability of culturing virus from them after day 15 or day 2 weeks. And then really the longest duration of being documented for someone shedding virus actively is day 20. So the vast majority is within 5 days. Yeah, some maybe within 10. The vast majority in the really sick within day 15. And the world record holder, if you will, is probably around day 20. So, the PCR test, the nasal swab, can pick up viral particles, which does not mean you're infectious. It just means that the virus died and broke up, and you're just kind of detecting its little bits and pieces still left in you, which is not a big deal. It's not going to cause an issue, but that can go, several days, weeks after the initial symptom. This is a study out of the Journal for Aerosol Science and Technology, which I don't read. I just heard about this from another talk, but it tells you about the power of masking. And here, forget about the red and blue. They're just basically different ways of measuring particle emissions from somebody, virus particles. And so if an individual who's infected is just breathing, you have this amount of virus particles that get emitted. When you do normal talking, you can kind of see it goes up a little bit compared to normal breathing. Then when you start talking louder, you see that the viral particle load that goes out into the air around that person goes up a little bit more. Normal singing is higher as well. And then if you have loud singing, it definitely goes up. And loud singing with exaggerated diction or high pitch, loud singing in general is one of the high risk activities. But if you have loud singing with a face mask, you basically cut your risk way down to that of normal breathing. And so it talks to about the power of masking and how it protects others around you. And if we all did that together, how much better we would all be. Last question before I finish. Some social media sites authored by supposed statisticians are giving unclear statistics about the number of false positive COVID tests. One suggests that 38% of the positive tests are really negative. Don't go down this road. I have no idea how to interpret this, because you're lumping, or this person or this group or whatever is lumping all the tests into false positives, false negatives. And it depends on the test, depends on when the test was done, it depends on what kind of symptoms and how well it was done in that individual. And it depends on how you're using the test as to the acceptability of the false positives, false negatives. And I just can't help but I'm becoming more of a pessimist about this, and I try not to get too political about these things. But I'm not sitting here taking sides. All I can tell you is say that a lot of these things are being used for political manipulation, in my opinion. It is clear that certain states that follow a certain politician, their approval ratings go up when the news about positive cases goes down, or when the rates of positive cases in community in that area is felt to be going down or lower. So there's a direct benefit for people to question the accuracy of tests, whether there truly are the number of positive cases out there, and for that matter, doing tests in general, because if you don't do as many tests, you're not going to get as many positive tests. So I would just really not go into the weeds of this. I think it just gets people generally confused, and it really takes your eyes off the real issue. And the real issue is that we need accurate, safe, affordable testing for everybody who wants it and needs it. Simple as that. And if we're going to start talking about all of this stuff, it just takes away our effort from that. And so there's a lot of good news coming along these lines that I've mentioned earlier. So let's continue to look forward and to hope and to pray and support the industry and the politicians and the public health experts as they work hard to continue along these lines for our benefit and others. So thank you again, Terry and the group. Continue, please, everybody, to support them. They didn't ask me to mention this, but the activities regarding the walk, the virtual walk, they depended on us so much for that throughout the year. And it's easy to kind of ignore emails and stuff these days. I know we get bombarded, but if you benefit at all from any of this and you have the means to participate in any of those activities, especially in fundraising and spreading the word and creating teams and just excitement and news, please do that. If you want to thank me in any way, that would be a great way to thank me along that regard. Please continue to send your questions to info@lfa.org by 3 p.m. on Sunday, and I'll continue to be here, and as long as you find benefit in that. And tell me if you don't, or you think we just need to spread things out even more. So again, many thanks to everybody. Please have a safe and good week. I'll see you again soon.